Hey, everybody. Welcome to Resiliency Radio, your go-to podcast for the most cutting-edge insights in functional and integrative medicine. I'm your host, Dr. Jill, and with each episode, we dive into the heart of healing and personal transformation. Join us as we interview renowned world leaders in medical technology and biohacking and all of the things that make us a better human and how to really just transform our lives in general. Today, I have a guest that I was on her podcast, so I wanted you to be sure and check that out. We'll leave all the links and talk about that. It's Bendy Bodies, that we just had so much fun, and I am super excited today to introduce her. And this topic, you may not realize how relevant it is to you, your family, your friends, or if you're a doctor listening, your patients. Is something that wasn't on my radar till the last decade or so, but it's had a huge impact understanding it on my practice and the kinds of patients I treat. So I know you're in for a treat. So let me introduce my guest and we will get to the interview. Dr. Linda Bluestein, MD, is a leading expert in hypermobility disorders, offering specialized care at Hypermobility MD. She also runs Bendy Bodies, I love the name, a coaching practice that empowers those with hypermobility. As host of Bendy Bodies with the Hypermobility MD podcast, which I was on, so be sure and check out that episode, she shares insights and fosters community. Dr. Bluestein is active in advocacy and research, serving on multiple boards, and you can learn more at hypermobilitymd.com. We'll be sure and repeat that at the end of the show. Welcome, Dr. Bluestein.
Thank you so much for having me. It's so great to see you again.
Yeah, it was so fun. And so let's first, I always love to start with your story because we all have a story of how we got into medicine and then eventually to our little niche of where we landed. But tell us a little about, did you always want to be a doctor? How did you get into this field?
It did start very early for me. I had a sister who had a lot of medical problems, so I went to a lot of doctor's appointments starting at a very young age, and she had some heart surgeries, so I was in intensive care to go visit her. And I remember, well, maybe it's partly that I remember, but my parents also telling me, that I would see the people in the ICU, walking around very quickly and doing all the different things with the drips. And I was immediately intrigued by that. And I actually knew from a very, very young age that I specifically wanted to be an anesthesiologist, which, I think is probably not something that a lot of people even know what it is, much less
Right.
that you want to do it, right? Yeah.
That's really cool. So you kind of knew this is my thing. I want to know more. And then, do you remember where that idea for anesthesiologist? Had you seen one or heard of it, or how did you find that as the goal?
Right. Well, that's the really funny thing about the what I'm actually doing for work now, because what I liked about anesthesia was the fast-paced environment and the fact that, basically every medication that you were administering was intravenous.
Yeah.
So it wasn't like, here, go work on this mold situation at your house
Mm.
or, prescribing different supplements or medications and waiting to see if it worked or not. It was completely different in that regard. So it's kind of ironic what I'm doing right now because it is so completely different. But I knew that I wanted to do something that was kind of a mix of a lot of procedures and also, of course, you had to understand all the medical, conditions that people would present with and understand about the different surgeries and how all of those would interact. So,
That's really cool. It is interesting because there's always like a little thread through, even if we think we're going to
mhm.
be orthoped and then we end up family medicine or whatever, like, oh, we like, so that's really neat. And it's almost like fast medicine, slow medicine, right?
Right,
I
right.
like the contra. Well, how cool. And then obviously now you're in this really specialized area that I think is so needed. That's why I was so excited when one of us reached out. I can't remember if I reached out to you or you reached out to me, but either way, it's just like really this area, so many patients either don't know that they have it or they know there's something different about their sensitivities, about how they are in the world, about their even their collagen vascular whole system, right? Because it affects everything. So let's just first frame hypermobility as a symptom of like EDS and some other things. But do you want to kind of give us a framework of where does hypermobility fit in? How many people do you think have an issue with this? And just give us a little background so that people who don't even know they might be suffering with this or having this condition can have some enlightenment.
Sure. So joint hypermobility just refers to a joint or a group of joints that have greater than expected range of motion. And it actually affects a very large percentage of people. I think a very conservative estimate is 20% of adults. But if you look at high risk populations like ballet dancers, and that's what I really wanted to do, was I wanted to be a
Oh,
professional ballet dancer. But I started to have too many injuries and things, so I had to come up with a plan B. But if we look at those types of populations, you can see like 90% of people have some hypermobility, and it can be acquired through training. It can be something that they're born with. There's different types. So localized joint hypermobility is when you just have it in a couple of joints. Peripheral joint hypermobility is when you have it in your hands and your feet, but not other parts of your body. Generalized joint hypermobility is when you have it in multiple joints. And historical joint hypermobility is when you were hypermobile in the past, but you're not anymore. And so, amongst that subset of people that have hypermobility, and of course, rates are higher in children as well. And in general, joint range of motion goes down as we age. So, that's also a factor. But amongst the people who have joint hypermobility, I like to think of a few different groups. So, there's the group that is pre-symptomatic. So, they don't have symptoms yet, but they'll develop them in the future. And then there's the group that is already symptomatic, and it could be a small number of symptoms, or they could be polysymptomatic. They might have symptoms, and as you know,
yeah.
like just about every bodily system, right? And then there's the people who are never going to develop symptoms. There are, people. We don't know how large or small this is, but I started to say small, but actually we don't know. We don't know how large or small the asymptomatic people are because if someone is in their 20s, say, and they're asymptomatic, we don't know if they're going to stay that way or not. But if they're in their 60s,
Yeah.
and they're asymptomatic, then that's a pretty good
Okay.
indicator. Yeah, yeah, that they're in good shape. And it's very possible that up to 3% of the population is affected by hypermobility spectrum disorders and hypermobile Ehlers-Danlos syndrome. And that amounts to about 225 million people. So it is very possible that a vast number of people are impacted by connective tissue disorders, which are a type of symptomatic joint hypermobility that, as you know, can impact every bodily system.
Wow, that was a really, really great and clear overview. Thank you for doing that because even for me, I'm like, okay, where does this end and begin with all the different things
Mhm.
that can happen? And that was really nice and clear. And even people thinking, so how would someone present, say, a 25-year-old athlete? What kinds of things would those with hypermobility notice as far as injuries or even other systemic symptoms?
So this is a great question, and I'm thinking of a 25-year-old professional ballet dancer that I just met with a couple of days ago, who I'd met with several years ago and was just checking in again to see, how she was doing. And, I think it's so often that a person might be athletic or maybe they're a dancer, and people assume that, oh, they must be fine. If they're doing their sport, they're doing their athletics, they're dancing, they must be fine. But in this dancer's case, it's very typical. So that's why I'm bringing her up. Of
Yeah.
course, I'm not going to mention her by name, but she's having pretty widespread pain. She's having a lot of orthostatic symptoms. So she gets
Mhm.
dizzy when she stands up, and, not just like, okay, you're behind on fluids, but like on a very regular basis, feeling pre-syncopal, maybe even some syncope episodes or losing consciousness, some temperature dysregulation issues. So heat and cold intolerance, not as, tolerant of temperature extremes as you would expect for an athlete at that level, especially. And you also see a lot of mast cell type symptoms. So allergic type phenomena, whether it be, like maybe allergic rhinitis, you might see asthma, eczema, rashes. This person did have, urticaria, hives that just came out of nowhere. And sometimes they were able to associate it with certain things. And other times it was like, wow, I have no idea where that came from. And it's so interesting because we talk about the joint hypermobility and how that's one of the core features of connective tissue disorders like EDS.
Mhm.
We think of the joint hypermobility, weak tissues, and changes in the skin. But really, the joint instability is probably more significant and probably more impactful in most people's lives. So it's the dislocations, subluxations, and things like that that in this dancer's case, that they're experiencing and is impacting their ability to dance. And at age 24, this person is thinking, I may need to retire after this season.
Wow. Wow,
Yeah.
that's such a big, I love that you started talking about all the other things because I remember, I don't know where the lecture was, but really starting to hear, we talked on your podcast about the triad, which you just described.
Yeah.
But for those listening, it's so common to see these things in groups. And one thing that comes together is this triad of mast cell activation, the hypermobility piece with or without EDS, and then also this dysautonomia, which can present with POTS or some sort of vascular thing. Now, my thought is that because the collagen system is such endothelial related, and when we have dysregulation of our blood vessels opening and closing, that's probably one of the things that develops the dysautonomia. But I'd love your insights because this is such a fascinating area. I see so many patients with that dysautonomia, whether it's running low blood pressures, changing positions. I always tell patients like a water tower, right? And you're not getting the water back up to your head. But do you want to describe physiologically maybe how that's related or how you see the dysautonomia POTS with the hypermobility?
Right. So just backing up to make
Mhm.
sure that everyone is clear about what we're talking about. So the autonomic nervous system, we call it autonomic, but you could think of it as automatic, right? So it's everything that we don't think about. So it's regulation of your heart rate, your blood pressure, your temperature, the size of your pupils, your digestion, all of these things, right? And we're all on kind of a spectrum of how well or not well this functions. And if you're in bed, even for a few days, right, with some kind of, virus or whatever, your autonomic nervous system already starts to function less well. My dad, who's an aerospace engineer, when he was working with astronauts back many, many years ago, they would put them in bed, perfectly healthy young men, because they had to see how they would tolerate being in space.
Wow.
And so they would put them in bed. And he said it was so challenging because, of course, they wanted to get up and walk around and so that was really hard. But it doesn't take much in terms of your ability to exercise before you start to see those kinds of changes. So I think that it's probably multifactorial, whether you have POTS,
Mhm.
postural orthostatic tachycardia syndrome, which is one of the most common forms of dysautonomia, or if you have neurocardiogenic syncope, which is, of course, another common form of dysautonomia where people are more likely to faint,
Yeah.
whereas people with POTS often feel faint, but they don't faint as much as those with neurocardiogenic syncope. And whether it's one of those two or a different type of dysautonomia, maybe it's orthostatic intolerance, orthostatic hypotension, we see these things so commonly with connective tissue disorders. And I think it's probably, yes, definitely related to the endothelium and the actual connective tissue itself. I think that there's a component of the deconditioning that happens when everything is painful and we get afraid to move. We get a lot of kinesiophobia, which I definitely had when I was very early in my understanding of my own personal hypermobile EDS. I was afraid to move because everything hurt. And so we get a little bit of deconditioning on top of these other physiologic processes that are going on. And then I think it's also the mast cell activation piece where we get, vasodilation, we get the histamine release and
Yeah.
inflammation and things like that. So I think it's a combination of those mediators, the actual, vasculature. And, I think it's probably a multifactorial process that's going on the immune system, playing a big role in there as well.
That makes
Beside, yeah. Yeah, sorry.
No, thank you. That makes so much sense. I love that you brought in the mast cell piece just as a thing in and of itself because we know that that causes permeability on all tissues and vasodilation. And I do believe that some of our patients, like where you started in the ICU, that are really sick or septic, obviously septic can be like those kinds of patients, you're seeing some of that be, severe hypotension and everything. And it's like an extreme state of some of these lesser extreme states that we see in the same hypermobile patients. Um,
Right.
I'd love to know, you mentioned, and if you don't mind sharing, I think people would really love to relate to your own journey. How did that happen that you found out? You probably didn't know about it until you found it in yourself. But tell us more about your own experience.
So it was years before I knew. So I had medical problems starting when I was very, very small. I had chemical intolerance. I had severe asthma as a baby.
Yeah.
And, my parents, again, they were dealing with my sister who was way sicker than I was. So my parents took very good care of me, but it wasn't like I was taken to the doctor a lot to deal with these more minor things. And so it wasn't until I was dancing a lot and really putting a lot of hours in that I started getting a lot of injuries, and they just weren't healing very quickly. And nobody suspected anything out of the ordinary, though. I started getting a lot of migraines. And like with a lot of our patients, right, when at the onset of menstrual cycles at menarche, that's when I really started to have more and more problems. I started to have more gut issues. My asthma got worse. I started to have, my allergies were horrible.
Hmm.
I literally remember telling my mother that I wanted to die. my allergies were so bad. And at that time, you had a choice of a first generation antihistamine, which would totally knock you out.
Yeah.
Yeah, yeah. Or nothing, we didn't have second generation antihistamines. There was no Zyrtec or Claritin or anything like that. So at that time, I just, was trying to muddle through and realized I needed my plan B. So, went ahead and went, to college, and I still danced all through college and was pre-med and everything. And then was having more and more health issues when I was in my residency in anesthesiology at the Mayo Clinic. I remember having so many GI problems. They were working me up for porphyria and all kinds of other things, and couldn't get any answers. I remember when I was working, telling my internal medicine physician, something is wrong with me. I don't heal well. I get injured so easily. And, was running into more and more problems, and I collided with someone on a dance floor, and I subluxed my ulnar nerve.
Wow.
I ended up with a huge cyst inside my lunate, which, is a bone in your
Yeah.
wrist. I ended up with a Tarlov cyst in my spine. So, all of those things were kind of starting to accumulate. And it was the Tarlov cyst that I was doing some reading about that. And I came across the sentence, Tarlov cysts are more common in people with connective tissue disorders. And I went, huh, that's interesting. So I started Googling about connective tissue disorders and came across EDS. And I found an article about hypermobile EDS. And I thought, oh my gosh, this literally explains my entire life. And I'm sure there's people listening to this right now who are like, oh my gosh, she's a physician and her story is exactly the same as mine in that regard. Because that's how a lot of people find out about it. They stumble across something and then they realize that that explains everything.
Thank you so much for sharing. I'm literally getting goosebumps as you're talking because I mean, so often our own journeys of these aha moments, I've been through many myself as well, that are just like transformative. And then they really change the trajectory of who we help and who comes to us and how our practice is. And obviously, I see that for you. And I remember seeking you out because I knew about what you did. And I knew that I had so many patients that needed to hear your message. So, like, it's so exciting to hear, even as a fellow physician, just what you did and how you found, and sorry you had to suffer, but also through that to find that and then to realize there's a name for it. I think anytime someone's suffering, that's why diagnoses are so powerful, but they're not the end, right? Because we have these
Right,
sufferings that don't make sense. And when a doctor can look at us and tell us our story and give us a name for it, all of a sudden it validates the experience of what we've had. So
right.
so interesting. I don't know where I am on the spectrum of EDS, but I know I had severe allergies as a child. And
Mm,
as I look through my history with the severe allergies, and then my brother had severe asthma, so there's a family kind of thing there, and then breast cancer and Crohn's disease, and then lots of POTS dysautonomia and mast cell issues
mm.
really my whole life. I also was thinking, I think the core thing is not just that I was on a farm with chemicals and that, which we can talk about exposures and how they affect it. But when I looked back recently, I gave a lecture and it was like, what if mast cell was really the core thing that led to all the other things? And my story made a lot more sense when I thought, oh, I'm one of those who has definitely mast cell activation, and just it came out in different forms, right? And just like for you with the dancing. So it was so fascinating because personally, I think that I have dealt with that too. And it's kind of been an understanding along the way to help patients. So you talked about some of the symptoms that you experienced and then like a patient that you treated. How might someone listening know that they should look into this more? We've kind of given these ideas of the POTS and the mast cell, but maybe give us like a checklist of the common things that you see the most often, or how you see someone who's been, maybe gaslit by the medical system, not intentionally, but they don't know what's going on. And then they talk to you and they're like, oh my goodness, this is it. How does that happen? What does it look like?
So I'm going to start out with the overview sentence that I think it was Heidi Collins, one of our colleagues, Dr. Heidi Collins, who said this first. If you can't connect the issues, think connective tissues. And
Brilliant.
yeah, it is brilliant. So if you have multi-system processes that are going on. Of course, there's other explanations, right? There's other things that connect all the different systems. But I think that it's really important to consider connective tissue disorders as one of the possible causes. And I totally agree with you. I did not appreciate at all in the beginning. When I first opened my clinic, which was only in 2017, I did not understand how important mast cell activation syndrome would be. I thought there's this pool of people that have hypermobile EDS. I understood a little bit about POTS because I had a family member that had quite significant POTS. But I thought, okay, there's going to be a small subset of people that have mast cell activation syndrome, and I know a little bit about what to do about that. But now I totally agree with you that I think that mast cell activation syndrome does underlie at least a significant portion of cases of hypermobile EDS, including possibly my own.
Mhm.
And so by stabilizing the mast cell, we can just make so much more headway in terms of our treatment options. But getting back to your question, I would say thinking, in terms of systems, if we think about the musculoskeletal system to start with, again, it's the subluxations, dislocations, which I should back up and explain. A subluxation is a partial dislocation. And so we often are going in and out of proper alignment with our shoulders and our neck and our patella, which is the kneecap, could be sliding in and out of proper alignment. So we often don't realize, like, I remember only after I started understanding about these conditions, one time I was taking off like a smaller-ish tank top and realized I'm probably at least subluxing, if not dislocating my shoulders when I take this on and off. And we only know what our own body feels like, right? So we don't know what is and isn't, quote, normal, if there even is such a thing. So the musculoskeletal things are, like I said, the subluxations and dislocations. We tend to get more sprains, strains, tendinopathy, bursitis, a lot of different, micro injuries and things. So it can be not microvascular. It can be micro trauma. That's the word I was
Yeah.
looking for.
Yeah.
It can be micro trauma or it can be macro trauma, like in the case of the subluxations and dislocations. So that's the musculoskeletal side, which also, by the way, can involve early osteoarthritis or osteoporosis, and osteopenia also can be connective tissue related. And then there's the non-musculoskeletal things. So, for example, with the gastrointestinal tract, it is very common for us to see, dysphagia or difficulty swallowing. We'll see, GERD or gastroesophageal reflux. We'll see, SIBO, small intestinal bacterial overgrowth, gastroparesis, or delayed gastric emptying. And of course, the challenging thing is a lot of those things can be related to dysautonomia and mast cell activation. So I don't know if you're familiar with that, like interlocking three circles.
Yes.
Yeah,
I know exactly what you're talking
I feel like a lot of us put that in our presentations because it's just such a good way of quickly explaining the Venn diagram of those three conditions and how, there's a lot of overlapping symptoms. So we don't know with some of these symptoms how much is related to the actual connective tissue and how much is related to dysfunction in the autonomic nervous system or dysfunction in the mast cells and their mediators. But okay, and then we can also see things like constipation, and that can be related to pelvic floor problems. That can be related to difficulties evacuating the stool. It can be due to the stretchiness of the colon. And we can also see diarrhea, though. And so those are some of the GI things that are very, very prevalent in this population. I mean, studies show up to 77% or maybe even higher of people with hypermobile EDS have gastrointestinal type symptoms. And then we also see constitutional symptoms. So fatigue is a very, very common complaint. I really didn't appreciate this until I opened my practice.
Yeah.
That 90+% of people with these conditions, hypermobile EDS and HSD, have chronic pain. And I should have mentioned it as part of the musculoskeletal part.
Yeah.
It's so like just natural to think
Right.
of it. But yeah, chronic pain is a huge, huge problem and it can be all of the types of
Mhm.
chronic pain, right? Okay, so then getting back to the other things. So fatigue is, I would say, the second most common concern that people have. So it's first pain,
Mhm.
then it's fatigue, then it's gastrointestinal problems. And then we see other things like, migraine, abdominal pain. We see just all kinds of, immune dysfunction. Again, things related to the mast cell activation syndrome. We see a lot of neurodivergence. So we'll see, ADHD, autism, and, dyscalculia, dysgraphia, dyslexia. So, difficulty with reading, with writing, and with math and things like that.
What a great overview. Thank you. So important and so fascinating because I think people listening can relate, especially if they had these serious symptoms, at least they can think about maybe this is a piece of the puzzle. I also love that you talked about mast cell because like you and I both are, that's been a big aha for me as far as how big of a deal it is. Now, one thing we talked about when we talked on your podcast too, but I'm sure you see that some people are just genetically prone to this. Most people are, but there's also environmental triggers, right?
Hmm.
Do you want to go through some of the things you see? Of course, mold is a big one. That's one thing
Hmm.
I like talking about, but there's other things too. Is there things where you see people with environmental exposures or infections or other things where they get worse with those exposures just because the mast cells can be a little irritable?
Definitely. So I'd say infection is a huge one,
Yeah.
whether it's, a vector-borne illness or it's a virus, COVID especially. I have so many people that, as I go through their timeline with them, they were
Yes.
doing fairly well, right? And then they get COVID and that really changes their health quite significantly. So that's a really, really common one. Sometimes it is a car accident
Yeah.
or a concussion or, something like that. But it's very, very common for people to have, they kind of putter along and they're doing pretty well. And then something like that happens and it really, really vastly changes their health.
Yeah, that's what I've seen. And again, I came in through the other door, which was more like I deal with environmental toxicity, mold-related illness, and lots of tick-borne or vector-borne or viruses or infections. But then all of a sudden I saw, oh, many of these people have the hypermobility triad and the mast cell. And so where would you start? So let's like transition to kind of treatment and assessment. Maybe we first talk about how would you diagnose? I mean, clinically is
Mhm.
huge, but are there tests for people? Give us kind of what your workup would be for the patient who sees you that's not sure if they have this.
So I like for people to have a basic rheumatologic type panel, which of course every rheumatologist orders a little bit different labs, every PCP orders a little bit different labs, but I think it is important to rule out some of the rheumatologic conditions because if somebody doesn't meet the stricter criteria for hypermobile EDS, which was introduced in 2017 by the International Consortium on EDS and HSD, if they don't meet that stricter criteria, or they don't have another condition to explain their symptoms like lupus or an acquired connective tissue disorder, then the default diagnosis would be hypermobility spectrum disorders. And for that, we have the ICD-10 code for hypermobility syndromes. We don't actually have a hypermobility spectrum disorder ICD-10 code at this point in time, even though we have a bunch of different codes for all the different subtypes of EDS. So we kind of start with that, making sure that they have either seen a rheumatologist or if their PCP has done those that's okay as well. If their PCP has evaluated for those things, that's fine. And then I go through the 2017 checklist, which is being revised as we speak. They call it the Road to 2026. I was part of the team of people who, was asked to fill out, oh, what's the word for it again? Darn it. I shouldn't have brought it up if I couldn't remember the
Surveyor. Yeah.
when they ask the experts to there's a certain method of doing that where
Yes.
they ask anyway. Okay, so they are working on the new criteria and that should be released later, I believe in 2025, actually the new criteria for diagnosing hypermobile EDS, because as you pointed out, it's a clinical diagnosis. It's the one type of EDS that we do not have a genetic marker for yet.
Got it.
So start with those things, go through the criteria, and then basically at the end of the evaluation for most of my patients, I either say you have HSD or you have HEDS, or if I'm not sure what type of EDS they have, but I think they have EDS, sometimes I'll put EDS type unspecified. Sometimes I recommend genetic testing, but definitely not always. It just depends on what I'm seeing and what I'm hearing them describe in their history, because for a lot of the other types of EDS, we're not necessarily going to have a different treatment plan.
Yeah.
It is validating if they have a genetically defined type of EDS. So if I think that they might, then I usually do order the genetic testing for that.
Oh, that's so helpful, and especially for those physicians listening. I want to know that code afterwards. The kind of but so just to clarify for those listening, we have the hypermobility kind of not otherwise specified that's not EDS that has no genetic markers. Then we have the hypermobility variant of EDS, and then we have EDS whatever listings there are under that criteria that would maybe have more genetic component. And the first two would typically not have any genetic component, whereas the EDS would actually have. Am I correct on that? Or correct me if I'm.
So it's a very, very good question if HSD is genetic or not.
Yeah.
And at first I thought the way it was being defined, HSD was not a connective tissue disorder, but it is, I think,
Yeah.
still considered a disorder of connective tissue,
Got it.
not necessarily a hereditary disorder of connective tissue, and HDCT, a hereditary disorder of connective tissue. The
Okay.
type EDS is the most common type of hereditary disorder of connective tissue. And under that umbrella also falls Marfan syndrome,
Yep.
Louis-Dietz syndrome, those kinds of things. Yeah.
Okay, that makes sense. Yeah, thanks for clarifying because it's like a map, right? That you guys, all
Yes.
the experts are creating, especially now that there's more and more people. So that's a
Mhm.
diagnosis, and in clinic you do the. Do you have on your website like the criteria? Or if not, we can link to the paper, the
I
main.
do I do have a link to the checklist. Yes.
Perfect. I thought so. So we'll make sure people have that the website at the end, and it'll be in the show notes if you guys want to look into that or see Dr. Bluestein. That's how you diagnose this treatment. This is complex because there's so many layers, but do you want to give a stab at that as far as how you start with treatment? Where do you begin with that? And not only maybe drugs, supplements, or things there, but also the movement is huge in how do they move their body. So I want to go to both aspects.
Sure, sure. So first I look to see, not just do they have an HSD or HEDS diagnosis, but where are they complaining of pain? So if their pain is really, really widespread, then I'm going to take one different tactic than if their pain is really localized into a couple of different joints. But most of my patients have central sensitization, they have nociplastic pain, they have pain that's quite widespread. So the acronym that I developed for that type of approach to kind of calm the entire nervous system, the acronym I use is MENS PMMS. And I published about this, I guess now it's 2 years ago
Awesome.
in April that I published these two articles in a CME journal. And so the letters stand for movement, education, nutrition, sleep, modalities, medications. Wait, no, I missed one. Psychosocial modalities, medications, and supplements. So that's
Awesome.
what the letters stand for. So yes, movement is critically important. So I don't care if you do gyrotonics, gyrokinesis, Pilates, working with a physical therapist, videos on your own, paying attention to your body, feeling your body, and trying to move a little bit more, just start low, go slow. But
Yeah.
it's really, really important to increase the amount that you're moving if you're somebody who's not moving a lot,
Yeah.
because that can really contribute to your symptoms.
Mhm.
And then a lot of people misunderstand the E. The E for education refers to neuroscience education related to pain processing. That
Mm.
was a really big aha moment for me when I learned about central sensitization and nociplastic pain, because I literally went, oh, that's what's happened to my body. I can feel everything that's happening. I was getting very light sensitive when I was in the OR in the
Mhm.
final, months and years when I was able to
Yeah.
work. I was just so sensitive to the
Oh,
lights. I would try to look into the open wound and figure out how much longer they had in the surgery, and I would really, really struggle with that. Obviously lights are really
yeah.
bright in the OR.
Yes.
So it's really important to understand that the nervous system plays a really significant role in this. So that's why, obviously, how important sleep is and how important the psychosocial aspects and everything. But, as I was coming up with my own treatment plan and realizing the different components that I was incorporating, I thought, okay, I need to come up with an acronym for this to help me remember when I see patients initially or in follow-up, am I addressing at least a significant portion of these various components that can help them improve their quality of life and their functional capacity?
Oh, that's so important. And I love that you're talking about that because we do have a lot of these patients that are just so sensitive. And there's a documentary, Pain Brain. Have you heard of that?
Uh-huh.
Yeah, which is addressing this very issue
Yep.
about how much pain is centralized. And this isn't
Hmm.
saying it's in your head, but there is a component that you become more and more. Well, sensitized is just the best word I guess we can come up with, where you experience things more. And we've seen this with like patients with IBS. There's clearly a correlation with how they feel their gut peristaltic waves more than someone who doesn't have IBS. So for them, it's way more painful just for the normal peristaltic wave to happen. And so this is a real phenomenon. I love that. Do you use things like DNRS or
Oh,
vagal
yes.
stimulators or all those kinds of things? What's some of your favorite limbic kind of things? Because I feel like that too is a big part of my practice.
Oh, that's huge. That's absolutely huge. So I love the Gupta program. I do also love DNRS. I have patients that have done, Primal Trust.
Yeah.
I have a whole list of ones that people have tried, and I love getting these kinds of resources from patients. Is when they share these things
Yes.
with me, I immediately write them down, and if they seem helpful, I share them with other people. So I think that's such an important component. And the other thing is psychologic stress activates mast cells, and mast cells release mediators that not only degrade connective tissue, but also increase sensitization both in the periphery and in the central nervous system. So mast cells are extremely important for the initiation and the maintenance of chronic pain. So they're involved in migraine and IBS and vulvodynia and all these pain disorders, CRPS, endometriosis. Mast cells are really, really, again, I feel like I keep going back to that, but it's,
Yeah.
they're big culprits in a lot of this.
That's so interesting because in the presentation I did a few months ago, I can still see the diagram from the paper we'll probably both have read recently, and it's just literally the circle of all the different pain, just all the ones you mentioned, and even suicidality, like people who
Yes.
is in there, and I'm like, it's shocking. Self-harm was how they described it, but it was pretty impressive to see the psychiatric manifestations of this as well: depression, anxiety, bipolar, schizophrenia, and again, I'm not saying all those are related to this, but there is a mast cell component to many psychiatric symptoms as well, which is years ago I was like, I wonder if most depression anxiety is not organic, but there's actually another secondary cause. And I don't know what the percentages would be, but the more I go into these fields of functional root cause medicine, the more I'm like, I don't know when the last time I've seen someone with a psychiatric diagnosis that didn't have a root cause that we could actually
Mhm.
change, right? So it's fascinating how this all connects, and the brain is not a
Yeah.
separate organ. So,
No, it's
yeah,
absolutely not a separate organ. And if you think about it, I mean, this between our ears is where we feel everything,
yeah,
right? So, although I think people think, oh, it's in my head. So therefore, someone thinks I'm making it up, but like it literally is inside
yeah,
our brain, which is inside our head, of course.
right, right.
So that's where we feel everything. And so for me, understanding about central sensitization was such a big game changer because I realized that if I could change my thoughts and if I could change my nervous system and try to calm my nervous system, and of course, I still need to work on that. It's something it's definitely
Sure.
a work in progress, but it's really important to understand all of these different variables because I think it's really empowering. It
Yeah.
gives us things that we can work on.
Oh, I love that. And what I've seen when I first read um, Susan Cain's book, Quiet, The Hidden Power of an Introvert in a World That Can't Stop
Mm,
Talking, and then the work of Elaine Aron on the highly sensitive person, right?
mm,
And these things kind of overlap. Not everybody with these symptoms has highly sensitive traits, but what I realized was the things that made me super susceptible to pain and mast cells and illness and sensitivities and all that childhood stuff that you and I both experienced, probably related to the mast cells, made me really sensitive to my environment, right? But on the other side of that, it gave me a skill as a physician where I can really be empathetic and be very
mhm.
sensitive to who I'm seeing in my office and maybe sense things that I wouldn't necessarily sense with my analytical brain, right? There's like a sense of like
Right,
where I should go, an intuitive sense that we then prove with science, but it's like the gift and the curse and the sensitivity.
right.
And in your realm, it's actually, I think there's many patients who have EDS, hypermobility, mast cell activation, dysautonomia, all the stuff we're talking about that are also highly sensitive trait individuals. Would you say that's
Yes.
true as well?
Oh, definitely. Yeah, definitely. And I think understanding for me that pain does not equal damage and that we can have damage in our bodies. I mean, I used to, when I was younger, I first of all, if I was offered a surgery for anything, I always jumped on it.
Uh-huh.
I thought surgery fixed
Would fix
everything,
it
you
up
know?
because you're
Yeah.
an
And
anesthesia. Yeah.
yeah, I was an anesthesiologist. I
Right.
spent my
Yeah.
entire life in the operating room.
Right.
And now I like, I try not to
Mhm.
have any surgeries if I can avoid it because, you see complications and things like that. And then you realize too that, people are walking around with damage in their bodies that don't necessarily have pain. So
Yeah.
I realized that, pain and damage are two different things. And, a lot of times people come to me and they're like, oh, but the XYZ practitioner told me that I have the worst spine they've ever seen, for example.
Yeah.
And that plants a real seed. I have a family member who I would say, as far as the sensitivity spectrum, is totally on the opposite end from me. I'm on that very, very
Yeah.
sensitive end for sure. This person is on the opposite end, but they had imaging of a part of their body and were told it was really, really bad. And that night, like the pain was so much worse.
Yeah.
And so we're all susceptible to
Yes.
that, even the
Yes.
people who are not as sensitive. And I think those of us that are really sensitive, we have to be very careful about how we word things. So physicians that are listening to this, our words matter so much. That's such an important thing to think about every single word that you use and how it's going to impact the person in front of you.
That may be the most important thing you said. And this is all such great information. I could not agree more because words have power and thoughts have power and our beliefs have power. And we think a thought long enough, it becomes a habit, which becomes a belief, which manifests in our bodies because our subconscious doesn't know the difference. So even though this seems like non-scientific, it's actually quite based in science, in how we think and how we process. And I really, really love because to our credit, it's not all in our head, but if we have pain, it actually gives us the hope that we can change that by how
Mhm.
we think about the damage. And I would say the same thing years ago. I did have some significant low back pain, and my MRI looks horrendous. I have no pain now. I would never get a surgery, right? But if someone looked at that and the wrong, the wrong practitioner was like, "Oh, you definitely need to have whether it's PRP, stem cells, or surgery," that's the kind of damage that someone might say that. But I don't have pain, and it's all about and you and I know too, if someone does enough MRIs, does enough imaging, you're going to find stuff, and it may not
Right.
be real. So
Yeah.
I always
Yeah.
like that. Oh, this is so helpful. What do you think if you would go back to your dancing younger self before you knew all that you know now? What bits of advice would you give her that you know now that maybe some young woman could hear?
Yeah, I would say the biggest thing is don't gaslight yourself. I had so many of my colleagues that gaslighted me, and I then gaslighted myself. Just because someone else doubts you, you don't have to doubt yourself. And I'm thinking of one particular incident that happened this was when I was not a young dancer. This is when I was working, but I think it's so important to trust ourselves, trust our instincts, trust how we're feeling in our bodies, and understand that, pain is the body's way of asking for change. And we don't have to be afraid of it,
Good.
but we should pay attention to it. And like you said with your back, like you paid attention to it. I'm sure you did some different things and you were able to get it to go away. So we should approach it with an inquisitive mindset, not an anxious mindset, and be curious about it. What is my body trying to tell me right now? And respond accordingly.
I love that. So it's like a message versus a
Yeah.
fear thing, because right, because most of us spiral into fear, like you said, it's so common. So there's nothing wrong with you if you're afraid of pain, but we can shift that and say, what is this trying to tell me? Instead of
Mhm.
running down a pathway to doom and gloom and surgery.
Yeah. Yeah. And that fear and anxiety tends to have this feed forward cycle that can
Yeah,
be really, really harmful. And then of course, anxiety makes the pain worse.
yeah.
And then the pain makes the anxiety worse. And so then we really end up in a lot of trouble. And that's what happened to me back in 2009, 2010 is when I was at my worst.
Mhm.
And I didn't have surgery for a lot of those things. I did have Tarlov cyst surgery in 2011, but there were a lot of other things that came up that I never had surgery for, like what you're describing with your back, and I don't have pain there now. So,
Yeah, yeah, it's
yeah,
totally possible to heal.
yeah.
And then if you can just catch yourself if you're out there and you're afraid, and obviously you have a website with resources. So maybe that's the next step. Obviously, I said in the show notes, we'll link to all of your social media and everything. But if people want to know more, are you taking patients? Are you coaching? How can people find you?
So I have a couple of different options. I do have a very small number of patients that I see, and I also do have what I call coaching. So if I am seeing someone in a different country and they can't fly here to be seen, which of course is really, really expensive, I have had people from other countries fly out here to see me, but if they can't do that, that's totally fine. I can see them on this coaching platform. So those are two options. If they can come and see me in person, either in Colorado or Wisconsin, which, as you know, medical licenses are state dependent,
Yes.
and those are the only two licenses that I have. So they have to see me in person in Colorado or in Wisconsin in order to become a patient. So that's one option. And then the other option is to see me as a coaching client. And if I see them as a coaching client, then I give them suggestions and things that they can work with their own local healthcare team. And then I also have my podcast, which you mentioned earlier. And of course, I was so thrilled to have you on as a guest. That was such a fantastic conversation. And it's called the Bendy Bodies Podcast. And through that podcast, I offer tons of information for people to take back to their own healthcare team and to use themselves. Because to me, the most frustrating thing about the triad is all the low-hanging fruit, whether it's doing DNRS or the Gupta program or something like that, or, taking some supplements, working on your nutrition, starting to move more, educating yourself about neuroscience. There's so much that we can do that we don't even need our doctor for. So it's really, really important to inform ourselves. And that's why your podcast is so important and my podcast is so important. These are things that people can use to improve their health, no matter where they're at on the spectrum of, their ability to pay for things.
Yeah. Oh, I love that so much because I feel the same. It's like the more information we can get out there that's free that someone might find, and it might be in another country, but they might. And I'm sure you've gotten emails and things from people like I have that will never ever be able to see me and never, but they heard something from a guest or from me and you're making a difference, which is so exciting. So from one HSP to another, right? I love
Yes,
that.
definitely.
Yeah, truly. Thank you for the work that you're doing. Thank you for putting it out there. Thank you for coming on today. It has been an absolute pleasure to get to know you better.
Been a really, really thrill. It has been such a thrill to get to talk to you. And I just really enjoyed getting to connect on my podcast and now on your podcast. And of course, we're actually now in the same city. So I just
I
moved to
know
the
we're
Denver
neighbors,
area a
which is
couple.
so cool. So I
I
can
know.
refer to you and all of that. And yeah, if you guys
Yeah.
are wanting to know, I don't know what number that was, but if you're driving, don't worry about taking notes. We'll put per
Oh,
podcast episode in my show notes as well, so that you can find that
mhm.
easily. Awesome.
Yeah,
Well, thanks.
definitely.
Yeah. Well, thanks again. And as you know, we do a new episode each week. So stay tuned for new information. And thanks again, Dr. Bluestein. Hey, everybody, Dr. Jill here at the end of another great episode. Wasn't that awesome with Dr. Bluestein and Bendy Bodies? I think there are so many patients suffering with hypermobility and not really understanding how it links to mast cell activation, dysautonomia. And I just really loved that overview. I hope it was helpful. As you know, we have new podcast episodes out every week. You can find us on iTunes, Spotify, or wherever you listen to podcasts. Please stop by, leave us a review. That would help us to reach more audience. And if you haven't seen, I'm so excited to announce that we have hit over 500,000 subscribers on our YouTube channel. Please go there if you're not subscribed, hit subscribe, hit the bell so you'll be notified of new episodes every week. And as always, thank you so much for your support. I am so grateful that we're able to reach that many people on these platforms and really educate them on all the things related to empowering ourselves and becoming healthier. If you haven't heard, I'm going on a retreat this spring and you're invited. If you want more information on the retreat, I'm going to be in Mexico at Sha Wellness. The dates are starting April 26th for 5 days or starting April 30th for 5 days. And you can find all the information at jillcarnahan.com/wellness retreats. That's jillcarnahan.com/wellness retreats. All the information is there. And if you can't come this spring, don't worry. I'll be coming back probably in the fall. So stay tuned for future dates. Also, if you don't know, surely you've heard by now, but my movie, Doctor Patient, is now streaming on Amazon Prime for free if you have the account, or on YouTube or Tubi with commercials. It's also available on Vimeo. So go to drpatientmovie.com if you haven't seen it, check it out. Leave me some feedback. Would love to hear how it has inspired you or your family who may have been suffering from chronic illness. Okay, I will see you next week. That's all for now. Take care.